Welcome, fellows from the East Coast, West Coast, and internationally. Thank you for joining us on the second week of July for our last fellow project lecture of the year for this fellow class. It has been an honor to get you content for the last year, and we look forward to the next year of fellows and hopefully you guys participating so we can all continue to learn together. A couple announcements before we get started. Our Bariatric Surgery Training Committee happy hour will be on July 25th. It's 8 p.m. Eastern, 7 p.m. Central. Please join in, run by Dr. Julianne Lloyd, one of our co-chairs for the Bariatric Surgery Training Committee. Then also, since it's the end of the year, it's time to put those numbers together. Make sure you get your bariatric training certifications in for ASMBS here in the next emails will be coming out, but all the information is on the website through asmbs.org. So take a look and start making sure you've got all the information you need to fill out your logs before you lose access to your fellowship EMR. And then I think most importantly, before I our panelists today introduce themselves, want to congratulate Dr. Dan and Dr. Jane Spangler and our committee here for being the ASMBS Committee of the Year. And that is a testament to the leadership of our Chair Emeritus, Dr. Adrian Dan. So congratulations to you and our team. On that, yeah.
Thank you, Shaina. I think it's more important to emphasize the team, the army of people that gets together. I think it's far more important than the leadership. It's the team that came together and did an outstanding job and were able to produce so much. And really, all you got to do is get Rickesha Wilson on your committee because she's on the committee every year that wins. So really proud of that, really proud of the team. And I think that it is truly a testament to all the work that everybody's put in.
And on that note, we will, real positive win, we will go ahead and get started. We're going to go over kind of the top learnings from ASMBS this year. So we're joined by Bariatric Surgery Training Committee members who will be helping us go through what our team thought were some of the highlights from June of 2024 ASMBS, the butterfly effect. And so, Dr. Dan, since you were already able to talk, please introduce yourself and tell us what you're thinking for the day.
Yeah, my name's Adrian Dan, and I'm thinking, gosh, we're finishing up here the fourth year of the Fellows Project. We've been able to put something together every single month, quality programming, and this is going to be no different. And I think it's important for us to reach out to some of the fellows who were not able to make the national meeting so they can get a taste of what you can expect at a national meeting where all your colleagues, your peers get together and all the minds come together, the discussions, the dialogues, the ideas that fly around really excite you, and you come back to your practice with so many things you're going to implement and do and try, and new friends, new collaborations, new contacts. It's really a great thing. I can't tell you how excited I get every year to go to our national meeting, to go to our weekend meeting, and I hope that none of the fellows that are watching would even consider not joining the ASMBS and being part of this really great society that allows you to learn, but also to serve and to be part of a larger collegial network that leads to the improvement of care of our patients and also advocacy and everything else. So I'll start. I don't know if you have a presentation, Shaina, but I'll kick it back to you for that, and then I'll tell you what some of the things that I got from the meeting were.
Great. Next on my screen is Dr. Rana Higgins joining us from Medical College of Wisconsin. She's our newest member to bariatric surgery training. What was your biggest learning for the year?
Yeah, thanks so much for having me. Super excited to be on this award-winning committee, and also for all the amazing work that's being done. As a fellow and having fellows every year, I can see the impact that all the educational programs that the committee has. So I'm glad you guys are all here. I would completely reiterate what Dr. Dan said. Coming to these national committee meetings and to these national conferences are so important for networking, but also just to learn so much from your colleagues. Bariatric surgery is such an exciting, innovative field. People are always trying to find better and better ways to take care of patients, and no better forum to learn it than these national conferences. So such a great meeting every single year. So we're excited to bring you some of that content today.
Yeah. Next, Dr. Scott Schimpke. He's now our co-chair as well for Bariatric Surgery Training Committee, coming from Rush University. What was your biggest learning for the year at ASMBS?
Wow, thank you, Shaina. Yeah, no, it's an honor to be part of this committee. It's every time we have committee meetings, I feel like we just have almost too much fun. It's a blast being with these people. So I really congratulate everyone for the honor that we got. You know, I try to actually go to all the sessions that don't make sense, or I maybe potentially disagree with, or are like stuff that you just kind of look at and like, what? Like, and so kind of challenge your mode, you know. In surgery, trust no one, trust nothing. And so I always tend to try to gravitate towards those meetings. You know, for me, the biggest, I think, overall theme for me is we're kind of at 15 years or so now after the sleeves really took off. And we're kind of in the meat of, you know, revision of the sleeve. And it's not so much the technical aspects. I think that is pretty clear, but kind of how do you navigate those patients? You know, we have all the medications coming out and continue to come out, and the revisions versus SADI, duodenal switch versus, you know, bypass. So there's so many different nuances that that we have to offer, which is great, but then sometimes that can be overwhelming. So I think a meeting like this can help you kind of maybe kind of formulate your own pathway, right? And so maybe you'll be up on the podium in a few years having your pathway of how do you approach essentially an underperforming or a non-performing sleeve. And so that's one of the things I focused on this year, but you could talk, and we will for the rest of the hour, about all the things that we saw at the meeting today.
And then last but most important, Dr. Rickesha Wilson, my partner in crime for the the fellow project coming from Cleveland Clinic. Tell us what you're thinking after the ASMBS meeting.
Yeah, thank you. Hopefully y'all can hear me okay. Good.
Yep.
Again, I'm Rickesha Wilson, and I'm in my 3rd year of practice, and I've been a member of ASMBS and a committee member since I was a fellow. So let me just make a plug for fellows and being involved. Being involved so early as a fellow was really instrumental in me being able to kind of contribute to the growth of ASMBS and meeting wonderful colleagues who I haven't worked with. Maybe I'll work with in the future, but I just want to encourage fellows. Committee membership is an excellent way, like someone else said before, just to network and collaborate and learn from others. And also it gives you the opportunity to contribute at these meetings. And so ASMBS is one of those meetings out of the many meetings we can go to every year with limited days and time away. It's one of the meetings I always go to every year. And I think this year, a big takeaway was a focus on the sleeve. First, the sleeve pass randomized trial, really being well put together and looking at the performance of the sleeve compared to the bypass, and kind of allowing us to have some numbers and some takeaways when we're counseling our patients and selecting the procedure and trying to figure out what patient might fit best. And then I was involved in the session and learned a lot in the foregut disorders after bariatric surgery session. And I even gave a talk on GERD after sleeve. But I thought it was interesting that a lot of people maybe mentioned that the sleeve to bypass is not the only option for reflux management after the sleeve. And so I thought that was interesting, as some people employ the sleeve to SADI or other interventions for reflux complications. So, but it was an awesome meeting. Had a great time just connecting with colleagues I hadn't seen in a while and meeting up with the colleagues I work with every day. So it was a great time.
Fantastic. Well, thank you guys for your introductions and your thoughts before we get started. The highlights that our team put together when we reviewed kind of our thoughts of the meeting. You've heard our panelists, but this is a reflection of the entire bariatric surgery training committee, was kind of how anti-obesity medications, are they replacing bariatric surgery? No, I don't think so, but we can talk about that. Kind of how we use these medications prior to and after bariatric surgery. So really trying to collaborate. Financial literacy, there was a fantastic session, and we are not going to be able to hit on all that, but that is a topic that we will hit on next year for sure. So stay tuned and come back. And then to Dr. Wilson's point about bypass is not the only option for reflux after a sleeve or in general, and the results of the sleeve pass. And my hope is that we get to also do the last two. There was some interest in learning a little bit about the DEMA stitch, and we have a video of DEMA doing his liver hammock suture. And so kind of jumping in for the first one, are we going to be replaced by anti-obesity medications? Lydia Alexander was the president of OMA this last year and came and gave a talk during one of our sessions, which was quite fantastic, talking about the importance of really kind of rising tide lifts all ships, meaning working together so we can start to affect treatment for more patients. And so as we move forward, annual healthcare expenditure for patients with overweight and obesity continue to increase, and this is historical data. And when you model it out in the future, it continues to rise to a pretty staggering effect. Have that data from Market Scan if anybody, or an advisory board if anybody's interested, but wanting to focus on what we talked about at the meeting. As we've kind of evolved to spend more money on the disease of obesity, our medications have gotten better and are now nearing efficacy of some surgery, with tirzepatide now being FDA approved with Zepbound in the last year. The real world, though, while these medications are getting better, it's quite challenging to get patients to take it. So kind of looking at all prescribers and real world trends of GLP-1s, almost 170,000 prescriptions were written from, and this is looking back, the adoption in the setting of obesity was exponential in the last year to 2 years, and it was pretty low rates of use prior to that. But the big things that are interesting to learn is only 30% of patients stopped using the medication within 4 weeks before reaching their target dose. 3 most common reasons for that: cost, insurance coverage, and side effects. And so it's not, even though we're prescribing it, there's a large number of patients who aren't going to do well with these medications for either reasons they can or cannot control. And then the hardest part, how do you improve it? For the 70% who did well, it's making sure they see their providers more consistently. In this current era, where I don't know if anybody's tried to get into a primary care provider, setting up a primary care provider can take a while. It's harder to get, took me 6 months to get into a primary care provider in September. I'm very excited to meet her, but it takes some planning and time. So setting up care may not be as simple as just calling a doctor and having him help you out with your medications. It takes some planning and time. Now, with that being said, as we've struggled with, we're seeing increased use of medications. At the same time, not everybody's been able to maintain that use. There's now 80 drugs that are in the pipeline for that are being trialed right now that will come out during our careers. Many of them in the next 5 years, 3 slated in the next 2 to 3 years. And so learning how to choose medications becomes super important. And that's one of the things that I thought was quite fantastic of these 5 C's. Like, how do you pick your medications? And Obesity Medicine Association does a fantastic job with education. And if you're thinking about utilizing these medications or partnering with a colleague who prescribes anti-obesity medications, American Board of Obesity Medicine does a quite nice job of educating and certifying and keeping you up to date on what's going on. And so ultimately, while more prescriptions are there, many patients aren't going to be able to utilize medications for the 3 reasons I mentioned. And so figuring out how we use medications becomes important, which is where some interesting studies are starting to come to play that were discussed at this meeting. So I wanted to pause there and see kind of what the team thought, what our panelists think of, are we getting replaced by obesity medications? And if yes, your thoughts. If no, how do we work together better?
Yeah, Shane, I can start. I'll say the answer is a resounding no, but I think there will have to be a shift in the way that we treat our patients. I can't help but go back and think of how people describe some of the other specialties that have had a lot of help from the medical side over the past few decades, particularly the vascular surgeons, and how they owned the space and learned how to use medical therapies also. So in that manner, you can actually provide a multimodality therapy for your patients. And I couldn't agree with more with the tide raises all the boats. The more people come in the doors and the more physicians visualize and see obesity as a medically treatable physiologic disease and dysfunction, the more opportunity we will have to render surgical care to those who meet the criteria.
Yeah, I would agree. And I think just like in the oncology space, you have adjuvant and neoadjuvant therapy. Medications can be just that. And of course, we should follow our patients and outcomes and do research, to see what the continued side effects may be of these medications. We know what the complications can be of surgery. And so I think we should learn kind of more about what medications fit certain patients or patient profiles or comorbidities. But I think it's adjuvant therapy. I tell patients at every visit, obesity is a chronic disease. Okay, post-op visit, hey, you're doing well, keep going. But things may change in 5 years, 10 years, depending on your medical conditions or life. So I think medications, I think we should really look at it in a positive light and kind of incorporate it, like Adrian said, in treating the chronic disease of obesity.
Yeah, I agree. And I would just add that it's just so important to be educated and to understand how they work. I totally agree that it's been positive. I think it's actually facilitated an easier conversation amongst providers and patients about not talking about obesity and in a light where people are uncomfortable talking about it. It seems that it's kind of helped bring the conversation forward a little more, and it's brought it a lot of media attention, which means that, maybe people aren't as hesitant to come forward to talk about the issues they've been having and perhaps trialing medications first, but then, having the conversation that surgery is a better long-term option. So I think it's been positive. I think we as bariatric surgeons need to be educated about it, but it's really helped the conversation of obesity feel less taboo and I think more comfortable for patients as well.
Yeah, I agree with everything. I think one of the things, and not controversial, but I think we're all biased in that we're all bariatric surgeons, but I think we have to also admit that bariatric surgery is not perfect, right? We all know that obviously there's going to be underperformers or non-performers. And so I think this is a perfect way to embrace those medications, because before the medications, we didn't have as great options for those type of patients other than to keep operating. And I think one of the most interesting things is trying to predict, who's going to perform well and who's not, and whether medications are going to have a part of that. I think that's going to be fascinating because that's really that's the ultimate, right? If you can predict who is going to perform well with medications versus surgery versus the combination of the two, I mean, that would be just unbelievably powerful to have that information. But I'm honest with the patients and say, look, if someone's already on weight loss medications, I'm like, absolutely, you should take it. Whether it's, a neoadjuvant, adjuvant, to use the metaphor of cancer, I think it's a wonderful aspect to have. And I get excited that patients are on medications, and I embrace it in my practice. And I think everyone else should too, not kind of run away from it or be scared of it. And so I think it's an exciting time. Obviously, we just don't know exactly how the perfect way to match everything is, but with so many things coming down the pipeline, it's limitless possibilities, which is a good thing for us.
Yeah, it's interesting when you start to a talk I heard at ASMBS, and it's a fact that I've been using to, I think, help understand kind of how the concept of we can all help each other out is of the people who meet the criteria for obesity in the United States, class 1 and above, we are only affecting treatment as surgeons for patients with OK class 3 or class 2 and 3 and above more frequently on about 1 to 2%. Obesity medications are now hitting about 9%. So there's room for all of us right now. And it's about kind of, I think, to the points that have been brought up of it's a way to work together and affect change and care in a way that helps more patients with time. And kind of to the points that Dr. Wilson and Dr. Schimpke brought up, this concept of kind of adjuvant and neoadjuvant segues nicely into a talk that was given by Tammy Kindle about how she and Dr. Higgins, her partner, who is joining us today as a panelist, have been able to integrate medical weight loss into their practice at Medical College of Wisconsin. And so she admittedly gave some disclosures as to how this pathway works for them. They are an academic center. They do have combined clinic space with endocrinology, so truly partnering with our medical colleagues, and that they have created an easy access to each other to affect, kind of to that point I brought up, it takes a lot of time to sometimes get into medicine providers for appointments. They've figured out a way to make it better for their patient population. And I think even cooler is pharmacy helping them with prior authorizations, which is, as many of the people on all the panelists definitely know, and unfortunately or fortunately, all the fellows on the call will learn, if you haven't already, takes a significant amount of time. And so this is the pathway that had been put forward that, by Dr. Kindle and the Medical College of Wisconsin, of when they use anti-obesity medications, either pre-op or post-op, or how they consider kind of that combination therapy. And considering we have one of the experts with us, I don't know if Dr. Higgins, you want to comment on how this has worked for your program?
Yeah, I mean, I think having somewhat of a algorithmic approach, I think every patient's unique, certainly, but having specific criteria that kind of trigger this, I think has been very helpful for us. We've always kind of sort of done this in a way where, you know, we collaborate very closely with our endocrine colleagues and we'll send them to see them. But now that we have, you know, a little bit more of a structure, I think it helps us because ultimately, as we've all talked about, obesity is a chronic disease, and pre-op, the idea behind giving medications is to get them to a place of safe surgery. So safer surgery, you know, for those with high BMI or central obesity, helping from a technical standpoint with more accelerated weight loss in anticipation of having a more straightforward surgery, ideally. And then obviously we know there are those who are undecided about surgery versus medicine. And I think a trial where we're fully integrated and kind of helping them with that, as opposed to them doing it through their primary care or a separate pathway, it helps us to have the conversation about the surgery up front, but then tell them, you know, it's okay, you don't have to make the decision now, because we all know that patients have to be invested in order to be successful. And so by providing them that, that's been helpful. Ongoing therapy and then uncontrolled diabetes are both things that I think really help in the pre-op period, again, to optimize in anticipation of surgery. So those are kind of the metrics that have been identified that have been helpful. Now, certainly there can be people outside of this, but I think, you know, if somebody comes in and is not currently on medications, those are the things that we consider. And then post-operatively, obviously trying to catch the effects of the surgery to maximize for those with early plateaued weight loss, ongoing diabetes, therapy, things like that. So I think just having some more structure has been helpful, as opposed to just, you know, deciding on a case-by-case basis.
I don't know if any of the other panelists are as jealous as I am about Dr. Higgins and the setup they have over there, but that sounds amazing.
It took many years in the making.
Yeah, I just want the fellows and people on this call to realize, like, this is amazing what they've been able to do. This is not easy to do. Unbelievable. So, and I'm sure you guys are probably working on some studies and things on the pathway that you have there. So that's awesome, by the way.
I think I give all credit to Tammy Kindle. She's our medical director. So
with the change in insurance and kind of how challenging it can be to get some medications approved, or the intense amount of documentation that can be required for approvals, having this setup or plan kind of puts guardrails on where when an insurance company come back and we like, hey, we audited, it gives you guys a language to use as a team that's founded in thought and true expertise from the team, which is, I think, is quite cool. Any other comments from the team? Anybody else have something like this in their practice? We're working on it as well, but we're years behind Dr. Higgins and Dr. Kendall.
Yeah, we have at Cleveland Clinic, we also have kind of an integrated space with a lot of the specialists in the same space, but we also do, of course, virtual. And then we're meeting this month, though, to kind of firm up our pathways, just kind of like this. So I think having pathways and kind of a plan of action for various patients with different comorbidities and situations is really important. So we're certainly trying to continue to do things like this. So this is awesome.
All right. So now that we got the creative juices going, let's get into the stuff that nobody ever wants to talk about, but is probably some of the most impactful things for a physician, whether you're a surgeon or a medicine provider or an anesthesiologist, et cetera, is kind of the financial literacy. There was a great session, and trying to sum up some of the words of the speakers during that great session is almost impossible in a 10-minute period because it's so important to learn. Colleen Kennedy gave a great talk on financial literacy, literally defining the words that we need to understand. So you can look at a balance sheet or a profit statement or billing statement and understand. And to be fair, I think I just learned about what those words actually mean and how interchangeable they are in the last month or two. It's every time I think I understand something, I get a new statement and you look at it and you're like, holy crap, I have no idea. And so we're going to touch on something that Dr. Clapp talked about because it'll be a little easier to do in a shorter period of time. And then through the year, we do have sessions coming up next year that are going to be a little bit focused more on the business component and the advocacy component, which will kind of lend itself quite well to the financial literacy. When you're starting out, it's overwhelming. And so I thought Dr. Clapp simplified at least one concept within financial literacy about how to optimize billing. Because if you optimize your billing, you optimize the thing you can control within your income. And so starting out, figuring out how to best create your own best practice before you are too far down the line and then have to change things, I think can be helpful. And what I appreciate about it is these are good skills, whether you're in private practice, academics, hospital employed, you're in a multidisciplinary group, et cetera. And so understanding what all that means and like the revenue value unit, what RVU means from a dollar perspective, and how do you optimize it so you don't leave money on the table. So the major key he mentioned is documentation. If you don't document it, it didn't happen. Don't document it, you didn't do it. If you don't document it, your thought process may not hold up also in court. And so your documentation becomes super important. And then big thing is if you don't document it, you're not going to get paid. Understanding some of the coding that we use, Medtronic has some really good resources online that are available to most people, but that will just list out all the CPT codes. And one of the things that you may, depending on what practice you go to, you may rely very heavily on your coders and your billers. They're not clinicians and they may not know what the codes look like. So while you're not going to be the expert in billing and coding, you need to be the expert in surgery, and understanding what codes could be used, I think, is important to have some of that dialogue besides understanding the vocabulary. And then CPT modifiers become really important. So one of the ones that I always remember to use and teach others is the decision for surgery. Say you're taking an internal hernia to the operating room that's coming through the emergency room. You want to use a 57 modifier because it actually allows you to bill better and get reimbursed for the fact that you're doing an emergency surgery or an urgent surgery potentially in the middle of the night or canceling clinic. They're going to have to cancel one billing opportunity, make up with another one. And so learn the different modifiers that you can use. And so one of the things I think from this, understanding your documentation, when you start, one of the orientations or at least conversations you should have at all times is with your biller and with your coder and with your compliance. Understand what they're looking for and what rules they follow. And they may have all of that figured out for you and send it to you on a presentation. I'd still recommend taking the time to talk with them and read through it. And then E&M codes, the clinic codes for inpatient, for outpatient. I keep a copy of the codes with me at all times, because sometimes I don't know which code to use, how to up or and make sure that my note is complex enough. And if I can't make it complex enough, document accurately how much time I spent with the patient. And those are important for inpatient, outpatient, and helps you differentiate the level. The big thing I think I learned from his presentation is 30% of our income comes from our clinic. So saying you can put just 5 words into a clinic note is a thought of the past. Really make sure it's accurate and complex. And he mentioned some numbers there. And then kind of making sure when you're looking at your, as you're billing and your paycheck, if you're going into private practice, academic centers, it may be a little bit more challenging, but private practice or hospital-based, you can negotiate how much you get paid for RVUs or per RVU. You can negotiate how many RVUs you should be doing a year. And if you hit that, how much extra money you make on top of that. Those are all negotiable. And so things that you, and actually that's negotiable no matter what practice you go into. Maybe not how much you get paid per RVU, but how many you do. And so those are things you want to be reflective of. And I'd be curious to learn, actually, let me pause. How many, would you guys feel comfortable sharing what your average RVU is per year? Not how much you make on it, but how much work are you doing based on that RVU? I'll share first because it can be uncomfortable. I am at an academic institution. I am 0.7 FTEs, meaning I'm 70% clinical. And so my RVU targets are based, are a little, like it's near 5,000. Where I came at a previous institution, my RVU targets were about 40 to 40% higher. And so there is a bit of a difference between institutions. And so understanding that can be really helpful. Yeah, love to hear y'all's thoughts.
The median for our specialty is 8,000, and then our 50 to 60th percentile benchmark, so around 4,000 to 5,000. Similar to Shaina, we're at a academic institution. I'm actually like 0.2 FTE because I'm 0.5 program director, and then I also go to the VA. So I really only have to do about 200 to 300 RVUs a month, but I do more than that, obviously. But it's an important language, and I think understanding what the expectations are very important. But at an academic center, it's certainly less because your full-time effort or your FTE, it can be dedicated to other administrative or educational things.
Yeah,
No, go ahead, Dr. Shchimpke.
No, well, Rana and I are very similar. I'm program director as well, academic institution just down the road. But yeah, I think in an academic institution, if you end up there, I think the FTE is the key thing to realize that is a way to lower the threshold and to allow you to do your other academic events or academic adventures, such as whether it's leadership, research, or whatever. So I am actually for program director, I'm only 0.4. I should be 0.5, but that's a whole nother story. But my threshold is around 5,000 RVUs. The other 2 cents I would say is, especially in the outpatient world, I 100% agree with Dr. Clapp, and I'm starting to learn more and more about this. I'm not an expert, but with those coding levels, you can bill either by the complexity, medical complexity, or time. Oftentimes the time is much easier for you and the coders to kind of hang your hat on. So, and it's not only the time you spend with the patient in the room, but it's the time you do prepare the patient and the time you spend afterwards looking over their chart. So oftentimes, especially for newer patients, longer visits, I actually use time, which is a very simple algorithm there, because you just put the time in the note. I spent such and such minutes with this patient. the billers look at the time, and then everything else doesn't matter essentially. So that is one of the things that can be useful. I found in the the outpatient world.
Also,
Perfect.
To that end, I bill mostly on medical decision making because I can get through a visit so quickly with a new patient. But every note of mine has documentation on the CAT scan that I reviewed, the endoscopy. So I have at least 3 or 4 studies that I document that I looked at, and I'm almost always billing at a 5 or a 4. 5 is the highest level in terms of outpatient. So I do bill on medical decision making because we as surgeons have learned how to efficiently kind of get through questions and whatnot. In terms of RVUs, here at Cleveland Clinic, I've never been told that there's a goal I need to hit, but they do send us reports. So last year I was at about almost 7,000 RVUs, and I'm 0.8 FTE. And so but that was transitioning from our main campus to one of our regional hospitals that's a lot busier, and I do a lot more general surgery calls. So.
Yeah, so the first thing I'm going to say is Scott's only 0.4 because he's more efficient than the average program director. So
I wish.
I think it's interesting how much discrepancy there is here. So I am in a community practice. We have a pretty large tertiary care center affiliated with a major university. So it's kind of a mix of everything. We have, I have a academic appointment. I'm 0.9 clinical though, the rest of the time being medical director and the fellowship, running the fellowship. But, my average yearly RVU is about 14,500, and that's after I slowed down a couple years ago because in this type of practice, it's really you eat what you kill, and there's some support for the administrative stuff, but I don't know, it's probably average at best, and it just the more you work, the more you're gonna be able to take home. That's an important part of what we do also. So it's important to realize as you negotiate this stuff, how the hospital makes money, how they get their reimbursement, how the world works, in other words. Otherwise, you won't be able to have a leg to stand on for negotiations if you don't understand. And the rules are also interesting, what you're allowed to talk about with the hospital. You can say, look, I bring a lot of value here, not only in what I do, but all the other tests. And they'll say, stop, we're not allowed to talk about that legally. And maybe that's very convenient for them, but it's important to understand those rules of engagement. So, from my standpoint, the kind of practice I'm in, it gets pretty darn busy. And I know my fellows on, she could attest to that. And I have 4 other partners that also are pretty darn busy and same kind of RVU targets.
I think the
But
important part is
certainly
learning.
that's something that you can negotiate. If you say, look, I want to work harder, or I want to work less, it's something that you can negotiate upfront with your employer and say, this is what I would like to be able to do. And also, I couldn't agree more with Shaina that you have to be able to say, okay, once I've reached that target, what do I get? Am I working for free? Am I getting more? Or is it the same? It's not something you want to find out as you get there.
Yeah. I'm not saying, and I don't think saying the metrics are the right thing. It's just the reality of what we have to deal with. And so being able to speak the language and have a conversation becomes really important. Knowing exactly what to be expecting. And a couple private practice colleagues of mine have given me pretty broad ranges of what their targets are per year, which range anywhere for ones that are consistent with academics to much higher, 15 to 18,000 RVUs a year. And so it really, with the variability that exists amongst practices, institutions, hospitals, et cetera, I think it's important to ask and then negotiate. And if you ever need help on it, there are some really good resources on how to negotiate for the business world. And in medicine, doctors are terrible at negotiating for themselves. White Coat Investor has some great resources. Harvard Business Review has some great resources. There's a few books that we can recommend as well. So if questions come up about negotiating or like how to ask for some transparency, let us know, let your program director know. And if they don't know, they hopefully know somebody they can connect you with, because learning this language becomes important for longevity of your career.
And
And
Shaina, if
then,
there's one thing I just want to add, one important thing here, because we have so many topics that we talk about, and once in a while, yes, we have to talk about money. It makes us so uncomfortable because very few of us, I would hope, have that as our primary focus. When we talk about targets, it doesn't mean, gosh, I got to find something to do to this patient so I can meet my targets. Your financial goals and targets should never, ever have any part of the medical decision making. What we're talking about here is how to negotiate something that you think is fair for you in order to be able to perform your job and to provide clinical services in a manner that's ethical to patients, and the amount of call that you have to take and the amount of cases that you're going to see new patients in order to make it work for you. But at the end of the day, your employer wants to say, that person, we're paying them X amount of dollars, and you know what? They're taking care of a lot of people. They're doing it with good outcomes. They're not rushing through them. They're making good decisions, the right decisions for the patient. And that's what we're talking about. So in order to justify that, how to get that perfect mix for yourself, that's what we're talking about in terms of target, but never this as a primary outcome of the success of your existence as a physician. So I think that's important to mention.
a question was asked that I think is quite relevant to answer now. Can you please explain how your salary is calculated based on your FTEs? If your output 7,000 RVUs and your 0.5 FTE, does that mean your income is calculated as if you're doing 14,000 RVUs? I would love to hear your thoughts, but I think there's not a straightforward calculation here at all. It's just a measure of common language. What do you guys think?
So administrative RVUs are paid at a much lower rate than clinical RVUs. When someone like Scott or Rana are taking on administrative RVUs, it's pretty much they're taking a pay cut and providing service, so they should be commended for that. That's so you're not getting the same amount of dollars you would be getting if you did another 7,000 clinical RVUs.
Yeah, our salary isn't determined by that. We do get, at least in our institution, we get we call it variable compensation is what our chair calls it, but essentially the bonus that we get at the end of the year is related to our, part of that package is our effort in regard to research, it's in regard to our educational effort, and it's in regard to our clinical productivity. That's all considered. And so it doesn't directly, for us in academics, there's no direct impact on our salary. That's predetermined.
All right. So we hit some billing, not enough. Definitely a lot to learn there. But it's the important part is to start asking questions. There are lots of resources out there. But to get to some of Dr. Wilson's stuff, now that we hit the stuff that we don't love to talk about, let's get back to the fun of, is gastric bypass the only solution for acid reflux? And so pulling from some of the talks, there are some interesting outcomes of, okay, what about using a 1 anastomosis gastric bypass, which is not as popular in the United States, and you may not have insurance coverage in the state you're practicing in or training in currently. Some states do cover it. North Carolina has some coverage. Massachusetts has some coverage. And I know there's more than that. It's just the only ones I know off the top of my head. But when you look at acid reflux outcomes based on PPI cessation, GERD, HRQL scores, there is, it appears when you compare, PPI cessation is higher with the gastric bypass compared to OAGB. Symptom resolution or GERD resolution may be higher with the OAGB, but when you look at the actual GERD HRQL follow-up scores in this small study comparing OAGB to bypass, the follow-up studies were, the scores were quite similar. they were just higher acid reflux scores preoperatively. And so they may have had more severe reflux, leading to a selection bias of more severe reflux, maybe got a gastric bypass, less severe reflux may have gotten OAGB. And this is one meta-analysis that combined 5 studies together. OAGB, when you look at smaller studies just at OAGB, there's some improvement in GERD HRQL scores consistent with that meta-analysis and improved symptoms to treat acid reflux. But it does have a higher rate of new onset GERD when compared to gastric bypass, which is likely related to bile reflux. So it's a balancing measure we have to talk about with that one. The other discussion, trying to think kind of quickly, ligamentum teres augmentation. There's a nice study that was put together by Dr. Clapp and Dr. Ghanem and Dr. Qatari, looking at 165 patients. They're using the ligamentum teres as a wrap. There was a 75% success rate for complete resolution of GERD and discontinuation of PPI after sleeve. So not actually converting to another surgery, but doing an augmentation instead, and getting kind of a wrap, not wrap physiology, but at least wrap anatomy. And then Daniel Cottom put together a pretty interesting talk and presented again a pathway that he follows, which I think is always helpful to share as one of the members of Dr. Wilson's session on how he looks at gastric bypass specifically, but tries to offer SADI for acid reflux and sleeve for acid reflux if it's more mild. I want to pause there because there's so much variable small data and get a really, comments from Dr. Wilson and the team, because I'd love to hear y'all's thoughts.
Yeah, so I really enjoyed this talk, and just for someone who in fellowship didn't really do a lot of SADIs and duodenal switches, I mean, I thought, bypass was really the main answer, but with the SADI and duodenal switch, you do have an element of diverting your source of bile by transecting at the first portion of the duodenum. So I think I just think these learning from people who practice in a different way than maybe popular or traditional can really just kind of help us to add tools in our armamentarium, because of course, even after bypass, reflux is not always automatically cured or for the long term permanently. So I think, and I thought it was just interesting with his pathway, even for those with the sleeve. I mean, his first step is a SADI with the hiatal hernia repair, and then fixing the hiatal hernia with mesh. I mean, gastric bypass, interestingly, is his last resort. And so I think this kind of information and insight just kind of can help us think and offer various options to different patients.
Yeah, and the sleeve gastrectomy as part of the SADI still preserves the pylorus, which is pretty darn nice compared to the OAGB. Dan has good data on this, and the data he came across in an accidental manner. He's looking at other things and just happened to see that, oh, by the way, in patients who get SADI and had sleeves and had GERD, their GERD improved. And he's followed up on that by further studying and developing these algorithms. But very much like the way I do my SADIs, he's a big proponent of taking down the right gastric, taking down all the attachments. You get that blue duodenum, that some people call the bluodenum, but you're also bringing that sleeve straight down. It looks like an upside down funnel. And just from a physics standpoint, an upside down funnel is going to want to drain things inferiorly, right? As opposed to the Titan Sashura retained fundus, old regular funnels that we used to have 10, 15 years ago, and people really complained of GERD after a sleeve. So there may be.
I'm gonna have to push back on Adrian's blue duodenum.
Oh, and the bluodenum. Yeah, I know you're not a fan of that, but it does really turn that sleeve completely down. And you can see from at least a physics standpoint, just based on gravity and retention of the pylorus, how you could have acid pass into your small intestine without refluxing up and that's one of the kind of Achilles heels of the OAGB, is that the potential for the bile reflux.
So I'm a proponent of Sadie for reflux after the sleep. I think the one thing to step back and really the kind of the overall theme is, one of the, we thought and kind of is advertised as a slam dunk, so to speak, is, oh, if somebody has a sleeve and they have GERD, it's like boom, bypass, right? And this is one of those examples where you want to challenge everything and really question everything. And we have to realize that, yes, bypass absolutely does a fantastic job there, but it's not perfect. There are other options, and even some people get converted to a bypass still have reflux issues. So you don't want to go down that tunnel blindly and realize that there are other options out there. Sadie, ligamentaries, all these other things, which I think is great. And one of the great things about our specialty is people are always challenging things, always looking at things, which is kind of getting back to the very beginning of the meeting, is like, that's where you go to these national meetings, because people are starting to think outside the box, and you might not go, you go, oh man, that's actually a really good idea. Bring that back to your practice. But yeah, I fully support the Sadie, and I do more traditional duodenal switch just for insurance reasons in Chicago. But bypass is not the only option, I think, is the overall theme here.
All right. Thank you guys. So let's keep going, because I think I may have missed probably the best talk because of a meeting at home from our keynote speaker and on sleeve pass. So would love to get everybody's thoughts. I pulled up the Sentinel findings of the sleeve pass study, which was a randomized controlled trial comparing head-to-head sleeve gastrectomy and gastric bypass for 10 years. And to Dr. Schimpke's point, you mentioned we're now getting into the 15 years of sleeve, which means we're getting long-term data and we can compare it to others. And there are comparison studies that show comparing sleeve to Sadie, sleeve to OAGB. This one focuses on sleeve to bypass. The figure 2 here on the left demonstrates kind of time since baseline and overall percent excess weight loss in the top, and then total body weight loss or percent total body weight loss on the bottom. And while there's a lot of similarities and pretty broad standard error bars, really cat and whisker bars, there is a significant difference between sleeve and bypass at 10 years, where weight loss is about 8.4 percentage points average lower than the bypass for percent excess weight loss at 10 years. Now, realizing that weight loss isn't the only thing, and there's a lot of variability in this data, which is why I think looking at the graphs, not just looking at the numbers, becomes important, they also looked at some of the outcomes and what was going on with acid reflux. There were a difference definitely in symptoms that were either no symptoms pre-op and symptoms that changed post-operatively. And there was less improvement in acid reflux with the sleeve and increased worsening of acid reflux with the sleeve in the sleeve pass study. But there was no difference in LA grade A or esophagitis prior to surgery. And interestingly, there was no grade D esophagitis in any of the patients that were part of this trial. GERD HRQL scores prior to surgery were, higher, actually, interestingly, with the sleeve on median range compared to the bypass. And then preoperative, the PPI use wasn't much different between the two groups. And so a little bit of difference, but some similarities, which I think was quite beneficial to learn about. And then in their supplemental data, they did start to look at improvements in comorbidities. And it was in, I think, supplemental table 3 in their major JAMA surgery article, but there have been multiple studies since that time. And this just shows there's the improvements for type 2 diabetes, dyslipidemia. It was complete resolution, not just improvement. And then they went in a little further with hypertension and sleep apnea, either complete remission or discontinuation of CPAP versus reduction in treatment versus no change at all. And the only significant difference between sleeve and bypass for comorbidity resolution was hypertension, where no change in the remission, reduction of medications, and no change in meds was different between sleeve and bypass, where it was there was higher rates of remission, reduction in meds, and lower rates of no change in medications with the bypass compared to the sleeve. But everything else in their study was similar. Would love to pause and get y'all's comments and thoughts on the sleeve pass study. And Dr. Wilson particularly would love to hear your thoughts here.
Yeah, the main author, she actually spoke at one of our Cleveland Clinic Live webinars maybe a month or two before the meeting. But I think kind of having a head-to-head trial of the two most common procedures that we do here, at least in North America, is really important for us to pay attention to, so that we can just better educate our patients and counsel them when selecting procedures and seeing what's optimal and then what's reasonable. I think from this study and like the ASMBS trial too, in terms of reflux, it kind of gives us a number to give. And I usually tell my patients, you may have there's like a 30% increase in new reflux or worsening of your reflux, just based on some of the numbers from this study and others. And so, but in that live webinar, there was a lot of contention, and there are some who believe that the sleeve is really an inferior operation and that we shouldn't be offering it. And not everybody is that extreme, but there are significant issues with the durability of the weight loss after sleeve compared to bypass. But of course, it is a simpler procedure, and of course, you don't have the risk of complications that the bypass does, marginal ulcers, internal hernias. And so, we're trying to, of course, still strive for the perfect operation, but I think this study is just excellent in just comparing the two most common procedures head to head. And these are hard to do, and we need these kinds of studies to inform our practice. And so I thought it was just helpful to help us as providers and surgeons who treat obesity to really choose better and counsel our patients as best we can.
Any other comments from the team?
So Shaina, I think this is a topic that we could easily fill a whole hour on in one of the fellows projects. I have very strong feelings about the fact that I believe that the sleeve is a wonderful procedure, and the outcomes and success of these operations, when Rickesha says the right operation hasn't been found, but is told not in years or in months but in decades. And you also have to take into account just how many times we reoperate on people for a gastric bypass versus for a sleeve, and the possibility that after a gastric bypass will be extremely difficult to convert somebody to what is the most powerful operation that we use today, the SADI or the standard duodenal switch. So what I took from it is not that the bypass is better, as many people did, because I believe this is a lot of work and a lot of years of follow-up to show that it's a little bit better, maybe that it reaches statistical significance, not necessarily clinical. But what I took of it is just how difficult these randomized controlled studies are to perform and how intricate the methodologies and the statistics are. Kudos to Dr. Salmanian and everybody else who's involved in these randomized trials for the tremendous amount of work that they do, so we can discuss them and make up our own minds as to how we feel about them. I'm not sure if I'll get the floor again because we're wrapping up here, but I do want to remind people, other than the ASMBS, one big thing we discussed at the national meeting is the importance for our members to also join the AMA. So if you are a fellow who's going to join the ASMBS, remain an AMA member, it affects our ability to have voice and to have representation at the AMA. That affects billing, it affects CPT codes, and so many other things in the politics of medicine. And finally, I also want to congratulate you, Shaina, on becoming the new chair of the committee, and of course, Julianne and Scott for your co-chairs. I think that's important, and you're a very humble person. You didn't congratulate yourselves, but congratulations. So
thank you. Realizing we're coming up the hour, and I didn't hit the last two things I was hoping, which is kind of what I expected. I planned more of the hour on the first, I think, the interesting topics. The DEMA stitch is a very cool stitch. If you get a chance to look, join ASMBS, then join active members of ASMBS on social media or Robotic Bariatric Collaborative. There's lots of really good tips and tricks that can help your practice as you evolve and grow. And the DEMA stitch is posted on all of those. If you're interested, I did put my email in the chat. I'm happy to share how to get to those resources. And then the last thing I wanted to bring up, because it came up during the metabolic associated steatotic liver disease session, are there guidelines for bariatric surgery in cirrhosis? And it was kind of one of the questions at the end of the session that I thought was fairly impactful and interesting. There are, based on Association Gastrointestinal, American Gastrointestinal Association, the AGA, put guidelines together in 2021, which can be helpful in making decisions on some tougher patient populations. And on that note, any final thoughts from our panelists today before we end 2 minutes over time?
You know, earlier, I just wanted to mention when we were talking about medications, it's not lost on any of us that it's really impacting the job market and kind of people's practices and volume. And as you fellows are even looking for jobs, but I would just encourage you to know that your skill set that you're developing in your training is what makes you a good surgeon. You know what I mean? Even if you're not going to land in a bariatric job specifically, you know, staying up to date on the information and having the skill set of doing intracorporeal anastomoses and treating the patients that we treat, that'll serve you well as a surgeon in general. And just don't be discouraged or disheartened. None of us know for sure how our practice is going to look like in 5 years. And so definitely be committed to your craft as a surgeon in general. And we hope you're not too discouraged about just kind of the changes and the shifts as you look for jobs and try to establish your career.
I think that's a great way to end our session. Thank you guys very much. I appreciate the time from the panelists, especially well, all of the panelists, and our chair emeritus, Dr. Dan, for joining back in, and Dr. Wilson for wrapping it up so perfectly. You all have a wonderful day. We'll see you next month.
Take care.